Did you know that 90% of the clitoris is actually completely internal?
Yeah, it's something most people have no idea about.
Right. And sitting right in the middle of all that hidden anatomy
Right.
is this incredibly critical, but like historically totally ignored component of female sexual response.
Ignored for centuries, honestly.
Exactly. And it's this highly complex web of veins called a Kobelt's plexus.
Yeah, the Kobelt's plexus, which is entirely hidden from the surface.
Wow.
I mean, for the longest time, anatomical textbooks basically just glossed right over it.
Just pretended it wasn't there.
Right. But this venous network, it essentially functions as like the master hydraulic control center for the entire pelvic region.
Which is exactly what we're getting into today. So welcome to this deep dive. Today we're pulling from a really fascinating stack of clinical scoping reviews on regenerative gynecology, alongside some very modern, detailed anatomical textbooks.
The ones that finally actually chart the true vascular structures of the pelvis, yeah.
Right, finally. And our mission for this deep dive, because I know you listening are always eager to really understand the mechanics without getting bogged down, is to figure out how a cutting-edge medical procedure is changing everything.
We're talking specifically about injecting platelet-rich plasma.
Right, PRP, injecting it directly into the Kobelt's venous plexus. And we're going to decode how that procedure is being used to literally rebuild the physical machinery of female arousal.
Yeah, and before we can even understand how a regenerative therapy actually rebuilds that tissue, we have to kind of unravel a lot of deep-seated medical misconceptions.
Because there are a lot of them.
Oh, absolutely. For a very long time, clinical science fundamentally misunderstood how this machinery operated. I mean, the visible part of the clitoris,
Glands.
right, the glands, it was treated as the entirety of the organ.
Which is just wild to think about when you consider that the glands alone is packed with over 8,000 nerve endings.
Yeah, it's incredibly dense.
I mean, that is double the nerve density of the head of the penis, right? Packed into a fraction of the space.
Exactly. But like you said, that glans is literally just the tip of the anatomical iceberg.
Just the tip.
Because internally, the structure branches out into these two massive crura.
Or legs, right?
Right, legs. And these legs are anchored directly to the pelvic bones.
Okay, so let's paint a picture for everyone listening. What are those legs made of?
So they're made of a specific type of cavernous tissue called the corpora cavernosa.
Okay.
And then beneath those, sort of surrounding the vaginal and urethral openings, you have two large vestibular bulbs.
And those are different tissue.
Slightly different, yeah. They're made of a spongy erectile tissue known as the corpus spongiosum.
Okay, we should probably define what that spongy tissue actually is because, well, it's crucial for literally everything we're going to talk about today.
Definitely.
So both the cavernosa and the spongiosum are filled with something called trabecular tissue.
Right.
So if you're listening at home, try to picture this like a complex three-dimensional mesh.
Yeah, like scaffolding.
Exactly. Scaffolding made of smooth muscle and connective fibers. And it's designed specifically to just trap and hold massive volumes of blood.
And that mesh design is brilliant, honestly, because it allows the tissue to expand dramatically without rupturing.
Right, it can stretch.
Exactly. But here's the thing. Those massive internal holding tanks, the legs and the bulbs, they can't just function as isolated islands.
The highway.
Right. They require a mechanism to move blood between them. And this is where the anatomy gets incredibly sophisticated.
Okay, break it down for us.
So situated right between the bulbs and the body of the clitoris is an area called the pars intermedia.
The pars intermedia.
Yeah.
And residing right inside that area is our star player today.
The Kobelt's plexus.
There it is.
Yeah. And the clinical texts describe it as this incredibly dense, vital network of veins. It acts as the essential circulatory bridge.
A bridge.
Right. It physically connects the venous circulation of the two cavernous legs with the two vestibular bulbs.
So instead of thinking of this as just some random collection of blood vessels, I think it makes more sense to view the Kobelt's plexus like a hydraulic manifold in a heavy-duty engine.
Oh, I like that.
Right. Because in an engine, you have a manifold that dictates exactly where pressurized fluid goes. It opens and closes valves to route power to different parts of the machine.
Yes.
So the Kobelt's plexus is essentially the manifold routing blood flow during arousal.
That manifold analogy actually captures the physics of it perfectly, because during arousal, that internal hydraulic system basically goes into overdrive.
Right. Where does it start?
The entire process initiates with the nervous system.
Okay.
When a person becomes aroused, local nerve endings release specific neurotransmitters, primarily nitric oxide.
Nitric oxide, okay.
And this chemical signal basically commands the vascular smooth muscle within that trabecular mesh we talked about to suddenly relax.
Wow. Okay. So the moment that smooth muscle relaxes, the resistance just drops to zero.
Yeah.
Blood from the main arteries just rushes in, and those two vestibular bulbs begin to severely engorge with blood. Like they physically inflate inside the pelvic cavity.
They do. But the body doesn't just let that blood sit there statically,
It's not just a puddle.
Right. It's a highly dynamic, highly pressurized process. Because covering those vestibular bulbs are bundles of muscle fibers called the bulbous spongiosus muscles.
Bulbospongiosa.
For
Okay.
a mouthful, yeah. But as the bulbs max out their fluid capacity, these muscles begin to involuntarily contract.
And when those muscles contract, they wrap around the engorged bulbs and physically squeeze them, right?
Yes, exactly.
And since that tracked blood has to go somewhere, it gets forced straight through our hydraulic manifold.
The Kobelt's plexus.
Right. It gets channeled directly upward into the body and the glands of the clitoris.
And that massive pressurized redirection of fluid through the plexus, that is what physically creates the erection of the clitoral tissue.
Which is just wild. We are talking about a major displacement of volume inside a very confined anatomical space.
A huge displacement. Which, brings us to the actual physical dynamics of intercourse.
Well, it's because things get even more compressed.
Exactly. The medical literature refers to this next phase as compressive phenomena.
Compressive phenomena. I mean, that makes sense because during penetration and withdrawal, those internal erectile bodies, especially those blood-filled vestibular bulbs, they're already stretched to their absolute physical limits.
They are incredibly firm. They're taking up significant real estate inside the pelvic floor.
Right.
So the physical friction and pressure of intercourse literally crushes against them.
It's literally a crushing force.
Right. And more specifically, the inward pressure crushes directly against the Kobelt's venous plexus.
The instar manifold.
Exactly. And because the entire manifold is already at maximum capacity, this intense physical compression forces the blood to seek alternative routes.
Where'd it go?
It gets pushed backward into secondary discharge pathways. Primarily, this area called the perivaginal venous plexus.
Okay, the mechanics of that backward pressure are just fascinating because squeezing that overloaded manifold creates a very specific physical effect.
Yeah, the textbooks describe it as a vice-like grip.
A vice-like grip between the female erectile bodies and the penis. The engorged bulbs actually physically clamp down around the lower third of the vaginal canal.
They do. And that grip heavily stimulates the anterior vaginal wall, which creates this intense feedback loop of sensation.
Right.
Furthermore, this intense congestion of the local blood vessels, the clinical term for it is hyperuremia.
Hyperemia, right
Yeah,
here.
it causes a massive spike in localized capillary pressure.
Okay, I want to break down that pressure spike for a second because I think it explains a biological function that a lot of people just completely
Oh,
misunderstand.
absolutely.
Right, because if you have this hyperemic traffic jam of blood, the pressure inside those microscopic capillaries just skyrocket.
And that fluid has to go somewhere.
Exactly. The high pressure physically forces blood plasma to filter directly through the walls of the vaginal epithelium.
Right. And the medical term for that fluid release is transudation.
Transudation.
Yeah. And it is actually the primary mechanism for vaginal lubrication.
Basically, the body is essentially sweating blood plasma directly into the vaginal canal.
Exactly, to provide the essential moisture required for comfortable copulation.
Okay, so I understand the mechanics of this, like perfect scenario.
Yeah.
But I have to play devil's advocate here for you listening at home and just look at the vulnerability of this entire hydraulic chain.
It's highly vulnerable.
Right. Because we are talking about a system that relies on flawless plumbing, massive blood flow, and the ability to sustain extreme or high capillary pressure.
Yes.
So what happens when those blood vessels inevitably degrade? As women go through aging or the physical trauma of childbirth or massive hormonal shifts like menopause.
Right.
When the manifold starts to rust, so to speak,
Yeah.
how does the system fail?
Well, the failure cascade is both structural and profound. When vascular health declines, the capillary walls actually lose their elasticity and the microvessels begin to collapse.
Oh, wow.
Yeah. So the system simply cannot achieve or sustain that high capillary pressure anymore.
Which means the transudation stops.
It stops completely.
So without the pressure forcing fluid through the epithelium, The natural lubrication dries up, leading to, I'd imagine, immediate friction and pain during intercourse.
Exactly. But it goes beyond just the loss of lubrication. Because of the collapsed vessels, the vestibular bulbs cannot achieve full engorgement.
The tanks can't fill up.
Right, the trabecular tissue just doesn't fill. The bulbs remain soft and basically under-pressurized.
Oh, I see. So when those bulbous spongiosis muscles we talked about instinctively contract to trigger an orgasm, they are essentially squeezing a deflated balloon.
That's a perfect way to describe it. They have no firm structure to contract against.
So the physical engorgement just falls flat.
It does, and you have to understand, the muscular reflexes of the climax rely entirely on that tissue being rigidly engorged. That's what generates the sensory feedback.
Right.
So when the bulbs are soft, the reflex is weak, which leads to decreased sensitivity and, severe difficulty or even an total inability to reach orgasm.
Okay, this highlights something incredibly important for the listener. Female sexual dysfunction, in so many of these cases, isn't just a psychological hurdle or a matter of, getting in the mood.
Not at all.
It is a literal physical failure of a highly complex vascular and hydraulic system. The plumbing is broken.
Exactly. And medical professionals have finally recognized this structural deficit, which is why the field has pivoted so heavily toward regenerative therapies.
Because you can't talk your way out of a broken pipe.
Right. We cannot just prescribe a psychological workaround for a collapsed vascular manifold. We have to physically rebuild it.
Which brings us to platelet-rich plasma, or PRP, commonly administered in this context as the O shot.
Yes, the O shot.
But I'm going to push back on this procedure a bit, because drawing blood from someone's arm, spinning it in a machine, and then injecting it back into one of the most highly sensitive areas of the human body.
It sounds extreme.
It sounds incredibly invasive.
Yeah.
And are we absolutely sure this isn't just a highly marketed, expensive placebo? Like, how does this golden serum actually rebuild tissue?
The skepticism is completely valid, honestly, especially given how PRP is sometimes marketed out there.
Yeah.
But the cellular biology behind it is rigorously documented in these clinical reviews.
Okay, walk us through it.
The procedure starts by drawing a small amount of the patient's own blood, usually just between 10 and 20 milliliters.
Which is essentially just a standard lab draw, right?
Exactly. And that tube of whole blood goes straight into a centrifuge.
Okay.
It gets spun at extremely high speeds for about 5 to 10 minutes, and this uses centrifugal force to separate the components based on their specific gravity.
So the heavy red and white blood cells sink to the bottom.
Right, leaving this clear golden serum at the top.
And that golden serum is the plasma.
Yes, but through the centrifugation process, the clinician is able to isolate a very specific layer of that plasma.
Okay.
A layer where the concentration of platelets is 5 to 10 times higher than what you would normally find circulating in your bloodstream.
Okay, but most of us just think of platelets as, the tiny cells that clump together to form a scab when we get a paper cut.
Right.
So why do we need a super concentrated dose of clotting cells for sexual health?
That's the million-dollar question, because clotting is only a fraction of what a platelet actually does.
Oh, really?
Yeah. Platelets are actually packed with highly potent bioactive molecules. They're stored inside these microscopic sacs called alpha granules.
Alpha granules.
Right. So when the clinician prepares the injection, they often activate the platelets. Sometimes they do this by introducing a tiny amount of calcium chloride.
And what does the calcium chloride do?
Well, that activation causes the platelets to degranulate. They literally burst open. Yeah, dumping their payload of growth factors straight into the surrounding tissue.
Okay, and the scoping reviews we're looking at focus heavily on two specific heavy hitters in that payload, right? VEGF and NGF.
Yes. Let's unpack VEGF first.
Which stands for vascular endothelial growth factor.
Exactly. VEGF is the primary biological driver of angiogenesis.
Which means the creation of new blood vessels.
You got it. When VEGF is released into a tissue bed, it binds to specific receptors on the outside of endothelial cells.
And those are the cells that line the inside of our blood vessels, right?
Right.
The mechanism there is just fascinating. Because when the VEGF binds to the receptor, it sends a chemical signal deep into the cell's nucleus.
Yes, it tells the endothelial cell to start secreting enzymes.
Enzymes that actually dissolve the surrounding tissue matrix just a tiny bit.
Right, just enough to create physical space.
Wow. Allowing the endothelial cell to divide, multiply, and physically sprout a brand new capillary tube that branches off from the existing blood vessel.
The metaphor of a root system is very apt here.
It really is.
because it forces dormant cells to sprout new vascular branches, actively expanding the circulatory network.
And then there's the second key protein, NGF, or nerve growth factor, which works in a complementary way.
Exactly. NGF focuses entirely on the nervous system.
Right. It stimulates the repair of the myelin sheath, which is basically the protective coating around nerves.
Yeah.
And it encourages the growth of new dendrites, which are the tiny branches that nerves use to communicate with each other.
So when you combine these two factors, it completely changes the nature of the treatment.
Because we're not talking about a temporary synthetic filler.
No, not at all. It's not like a cosmetic injection that just artificially plumps the tissue for 6 months until the body breaks it down.
Right. So to synthesize this for you listening, it's like you're dropping a highly concentrated autologous cellular construction crew directly onto a crumbling highway.
Yes.
You are supplying the local tissue with the exact genetic blueprints and biological materials it needs to pave new vascular roads and lay down new electrical wiring.
That localized, accelerated healing response is just profound when it's applied specifically to our hydraulic manifold.
So when clinicians introduce this PRP directly into the pars intermedia,
Targeting the Kobelt's venous plexus and the surrounding anterior vaginal wall, yes.
right, the moment that serum hits the tissue, the VEGF just goes to work on the manifold.
It does. It stimulates the endothelial cells within the Kobelt's plexus to sprout new capillaries.
And over the course of several weeks, the physical density of the venous network actually increases dramatically.
Which means the structural capacity of the plexus to handle blood volume expands.
The pipes get bigger.
Basically, yeah. The trabecular meshwork inside the vestibular bulbs and the clitoral legs now has a robust, healthy supply line.
So a significantly higher volume of blood can be delivered and, honestly, more importantly, retained during arousal.
Exactly. The hydraulic pressure is officially back online. The bulbs can expand fully once again.
But the NGF is working simultaneously, right?
Yeah.
On the electrical side of the system.
It is, yeah. It's regenerating the local nerve endings in the clitoral complex.
And that nerve regeneration is just as critical as the vascular expansion.
Oh, absolutely. Because remember, the entire hydraulic cascade begins with a neurological signal.
Right.
When the local nerves are healthy, when they're heavily myelinated and highly sensitive, the release of nitric oxide is much, much stronger.
And a stronger neurotransmitter signal means the vascular smooth muscle relaxes much faster and far more completely.
Yes.
It essentially throws the floodgates wide open, allowing that massive rush of blood to flow into the trabecular tissue without any muscular resistance at all.
Right. The plumbing is wider, and the electrical signals commanding the valves to open are firing flawlessly.
And the clinical scoping reviews actually provide hard empirical data to support this mechanical rebuilding, which is amazing.
They do. In sexual medicine, researchers utilize a standardized diagnostic tool called the Female Sexual Function Index, or FSFI.
Right, the FSFI. It's basically a comprehensive questionnaire that measures desire, arousal, lubrication, orgasm, satisfaction, and pain on a point scale.
And the numbers from these PRP trials are just staggering.
Yeah, they really are. In one of the key targeted studies we reviewed, women suffering from severe sexual dysfunction who received this specific PRP treatment saw their average FSFI scores jump from an 18.1 all the way up to a 29.4.
Which is a massive leap. Just to put those numbers in clinical context, an 18.1 indicates profound dysfunction.
Very profound.
Yeah, it represents patients who are likely experiencing active pain during intercourse, zero natural lubrication, and a complete inability to achieve climax.
But a score of 29.4.
That crosses the threshold back into normal, healthy, pain-free sexual function.
Which is incredible.
Yeah.
And if we trace those improved scores backward, they map perfectly to the anatomical reconstruction we just broke down.
They do.
The pain decreases and the lubrication returns because the capillary pressure in the Kobelt's plexus has been restored.
Right, that high pressure forces the transudation of fluid through the vaginal walls again.
The natural sweating of the plasma.
Exactly. And the heightened arousal and desire correlate directly to the NGF repairing the nerve endings.
Making the anterior vaginal wall deeply sensitive to the compressive phenomena of intercourse again.
Yes. But honestly, the most mechanically satisfying outcome here is the return of the orgasm itself.
Right, the grand finale of the manifold.
Exactly. Before the PRP, the vascular degradation left the vestibular bulb soft, right?
Right.
So the climax was weak because the bulbous spongious muscles were just contracting against a deflated structure.
But following the PRP therapy, The Kobelt's plexus can fully manage that massive fluid transfer.
Yes. So the bulbs become completely engorged, rigid, and firm.
Right. And now, when the neurological threshold is reached and those muscles instinctively spasm,
They are forcefully squeezing against a highly pressurized, firm surface.
the muscle finally has its rigid backboard again.
Yes. And that intense, throbbing physical resistance is what generates the sensory feedback that the brain actually registers as a powerful orgasmic reflex.
It is a complete, literal, mechanical restoration.
We really covered an immense amount of biological ground today.
We did. Moving from the invisible anatomy of the pelvic floor all the way to the cellular mechanisms of platelet degranulation.
Yeah.
We pulled back the curtain on a system that medical science ignored for far too long. We established that the clitoris is this expansive internal organ, and we mapped out how the Kobelt's plexus operates as the central hydraulic manifold.
Seamlessly managing the pressurized blood flow between the vestibular bulbs and the clitoral body.
Exactly. And we outlined how the physical friction and compressive forces of intercourse rely entirely on the vascular integrity of that manifold,
Because when the microvessels degrade over time, the system loses its internal pressure.
halting lubrication and preventing the erectile tissue from properly inflating. Yeah.
Yeah. But the science of platelet-rich plasma offers a true structural solution.
Right. By isolating a patient's own platelets and harnessing the payload of growth factors like VEGF and NGF, clinicians can inject that autologous serum directly into the Kobelt's plexus.
And it forces the body to sprout new veins, repair damaged nerves, and ultimately restore the physical capacity for engorgement and muscular climax.
It is just a brilliant intersection of detailed anatomical mapping and targeted regenerative biology.
It really is.
And we know that, for you listening, understanding the absolute why and how behind a medical procedure is vital.
Absolutely.
The O-shot isn't just some superficial wellness trend. It is functional biology at its finest, using the body's own genetic blueprints to repair structural wear and tear in a highly sophisticated hydraulic system.
The implications for women's health and longevity are profound.
They truly are. And it leaves us with one final kind of fascinating thought to ponder as we wrap up today.
Oh, what's that?
Well, if we can successfully use the concentrated growth factors in a patient's own blood to literally grow new vascular networks and regenerate nerve endings in a system as delicate and complex as the Kobelt's plexus to cure sexual dysfunction,
Okay.
could we eventually map and use these exact same autologous PRP therapies to cure the complex systemic pelvic pain disorders like endometriosis or vulvodynia that have absolutely baffled traditional medicine for centuries?
Wow.
Right. Just imagine what else the human body can rebuild if we can just figure out how to give it the perfect construction crew.